Okay, so we're going to trace the path of a disease that starts with something as simple as a sore throat, but can end up causing life-threatening heart damage. We're talking about rheumatic heart disease. And what's crazy is, it's almost entirely preventable. So yeah, how does that happen?
I mean, it sounds pretty unbelievable, right? A simple sore throat, leading to major heart surgery? How can something so common spiral out of control like that? Well, that's exactly the chain of events we're going to unravel here. We'll go step by step from that first infection all the way to the path back to health.
Okay, so here's the critical link. Rheumatic heart disease, let's just call it RHD, is the end result. It all kicks off with a basic strep infection. Now, if you don't treat that, your body can kind of overreact with this massive inflammatory response called rheumatic fever. And that inflammation, it can permanently scar the tiny, delicate valves in your heart. That scarring, that is RHD.
So, here's our game plan. We'll look at prevention, a new way to diagnose it, how to stop it from getting worse, what it takes to fix a damaged valve, and finally, the road to recovery.
All right, first up, let's start where this whole story really should end, with prevention. Because the entire devastating chain of events we're about to walk through, it all starts with something we absolutely know how to stop.
And this is why it's such a big deal. You know, RHD isn't some disease of old age. It hits kids and young adults, right in the prime of their lives. It's actually the most common heart disease that people acquire that they aren't born with, especially in many parts of the world and in at-risk communities.
So, for a long time, catching RHD early was really tough. But now, there's a new set of guidelines out there that are a total game changer. They give doctors this ability to see and classify the damage with, honestly, incredible clarity.
And this is a huge shift in how doctors think about it. I mean, up until 2023, they were using these kind of vague terms like borderline or latent RHD. They were confusing and didn't really tell you what a patient's risk was. Well, the new World Heart Federation guidelines, they just swept all that away and brought in a super precise, stage-based system.
So this new system is basically A, B, C, D. It's all about classifying the disease based on how likely it is to get worse. Stage A, that's just minimal changes in young people. But stage D, that's advanced disease with really serious stuff, like heart failure. Having this kind of clarity, it's a total game changer when you're trying to decide on treatment.
So how do they even find these early stages? Well, they use ultrasound screenings, echocardiograms. In kids and young adults, doctors are looking for these super specific signs, like they'll literally measure a tiny jet of blood leaking from a heart valve. We're talking about something as small as 1.5 centimeters. Catching it at that microscopic level, that is the absolute key to preventing a lifetime of damage.
Okay, so once you've found RHD, even a mild case, the mission is crystal clear. You have to stop it in its tracks. And believe it or not, medicine has a surprisingly powerful tool to do just that.
That tool is called secondary antibiotic prophylaxis, or SAP for short. The idea is actually pretty simple. It's just regular, long-term doses of antibiotics, usually penicillin. And let's be clear, this isn't to fix the damage that's already there. Nope, it's all about preventing any new strep infections that could cause another bout of rheumatic fever and make the valve damage even worse.
And the strategy here is all based on risk. The more advanced the RHD is, the stronger the recommendation for these preventative antibiotics gets. For patients in those later stages, C and D, it's not just a suggestion. It is an absolute must-do to protect their heart from any more damage.
But what happens when prevention just isn't enough? What if the damage to the valve becomes really severe? This is where we have to talk about one of the most serious outcomes of RHD, and that's when the mitral valve gets dangerously narrow. It's a condition called mitral stenosis.
Really, it all boils down to one critical number, a mitral valve area of less than 1.5 square centimeters. Okay, so think of your mitral valve like a one-way door between two of your heart's chambers. In this condition, the flaps of the door get thick and actually fuse together, jamming it so it can't open all the way. That number means the doorway is so narrow that the heart has to struggle like crazy with every single beat.
And figuring out how to fix this, well, it's not a decision one doctor makes alone. The modern approach is to have a heart team. It's this whole group of specialists, cardiologists, surgeons, you name it, and they all work together. They look at everything: the patient's age, the exact shape of their valve, their overall health, all to figure out the absolute best way forward.
So the heart team basically has two main options on the table. The first choice, if the patient is a good candidate, is something called percutaneous mitral commissurotomy, or PMC.
It's a really advanced, less invasive procedure. They guide a catheter up to the heart and literally split those fused valve flaps back open. But if that's not an option, then the alternative is full-on open heart surgery to replace the valve completely.
So you're probably wondering, why not just do the less invasive PMC for everybody? Well, there are some specific deal breakers, things that make it a no-go. For example, if there's a blood clot hanging around, or if the valve is just too stiff and calcified, or if it's also really leaky, PMC just isn't going to work. And in those cases, surgery is the only path forward.
Now, whether a patient gets that PMC procedure or has open heart surgery, a successful operation isn't the end of the line, not even close. It's really the start of a whole new chapter, one that's all about long-term health and management. The whole point is to make the benefits of that procedure last a lifetime, right? And that means you need a serious plan for follow-up care, because things can happen down the road. You could get what's called restenosis, where the valve starts to narrow again, or you could have issues with a replacement valve.
And this follow-up isn't random, it's very structured. After a successful PMC, for example, you absolutely need a checkup within a year to catch any signs of that re-narrowing. If you have a replacement valve, you're looking at yearly checks. It really becomes a lifelong partnership between you and your medical team.
And this brings up a really crucial point from the guidelines. Because RHD hits young people so often, getting the whole family involved isn't just a nice idea, it's essential. The family has to understand the condition, the need for medications, the lifelong plan, especially for young women who might be thinking about having kids one day. It's a huge deal.
So when you put it all together, you can see that the modern approach to rheumatic heart disease is this complete, connected pathway. It literally starts with preventing a sore throat from ever doing damage, and it goes all the way through to providing lifelong care after a major heart procedure.
Look, we've made some incredible progress in how we find and manage RHD. The path forward for patients is clearer than it has ever been. But that just leads to the biggest question of all, doesn't it? With all these new tools and all this knowledge, what's it really going to take to go from just managing this disease to wiping it out for good?